please record this. I want this transmitted. Connection pantingla. Connection paniyacha. Sir, give us 2 minutes. Just getting this recording ready. Recording ready?
Ready.
Ready. So record it, please, and have the transmitted. Keep the cable here. Yes, sir. Please.
I would like to thank the organizers of the MICRONEUROSURGERY workshop for giving me this opportunity to speak in front of this august audience. Let me briefly tell you the saga of visualization through tubes, starting from Sushruta Samhita to endoscopic neurosurgery as it is today, in a brief way. Next. As long as medically inclined people existed through the ages, I suppose there's always an interest to look inside the body. And in Sushruta's time, perhaps much of what was done in looking into the cranium was because of the injuries that were sustained by people of that time in warfare. This shows a poster of some of the instruments which were supposed to be used in that time. Some of them which are still existing today and used in maybe in a more polished way. Following Sushruta, there is mention of Jivaka, 500 BC, who became famous after curing the king Bimbisara of a fistula and was appointed as the personal physician. He subsequently became the physician of Lord Buddha. Jivaka has been depicted in healing misplacement of intestines, trepanation on a patient, removing intracranial masses, and performing no surgery. Remember, this is 500 BC. Next. Perhaps in the latter days, the more significant issues, persons who did some work in developing this field, perhaps the beginning would be Bozzini in the early 1800s. He tried to visualize the urinary tract using a tin tube, and the lighting which he used was a wax candle which was reflected by a mirror. This idea at that time was dismissed as extremely preposterous and had no future by the elite at that time. In 1910, Victor Darwin Eskenazi was actually a urologist in Chicago, reported to a society there about a fulguration of the choroid plexus in 2 infants with hydrocephalus using a cystoscope. Though one child died immediately, the others survived for 5 years. Next. Following him was Dandy in 1922, Johns Hopkins Hospital. He had earlier on reported experience in performing open choroid plexectomy through a transfrontal route. He attempted the same thing using an endoscopic choroid plexectomy in 1922. It did not turn out to be successful, but he continued his work, and in 1932 he also reported the removal of a choroid plexus using a cystoscope, which he had modified. The results were found to be similar to the surgeries he had performed with the open formal craniotomy. In 1923, Fay and Grant were the first ones to successfully photograph the interior of the ventricles of a hydrocephalic child using an endoscope. It is interesting to note that the exposure time that was taken for taking these images was between 30 to 90 seconds, which highlights the quality of the light that was available and the poor lighting and the visualization being so poor at that time with the technology that was available. Putnam in 1934, 2 years after Dandy had performed his choroid plexectomy, he adapted electrocautery, and he used one of his cystoscopes, which he had modified and made it into a ventriculoscope. He used the electrocautery to cauterize the choroid plexus in patients with communicating hydrocephalus. But Putnam is maybe more famous for his discovery of the anti-seizure effect of dilator. There was no widespread acceptance of endoscopy in neurosurgery, definitely in the early part of the 1900s, the 20th century. probably because of the poor technology that was available, the extremely poor lighting that was available, the poor optics, the poor quality instruments which were made of poor quality materials, and also in addition to that the high death rates with these procedures. Next. When in 1952 Nelson and Spitz reported the creation of a shunt diverting cerebrospinal fluid from the ventricular system to the jugular vein to successfully treat a communicating hydrocephalus, this sounded the death knell for ventriculoscopy at that point in time. This began a monumental shift in the hydrocephalus treatment paradigm towards shunt diversion, and hardly anything much happened after that. Perhaps very critical in the development of ventriculoscopy was Harold Hopkins and Narinder Singh Kapani. Many people think that when they see the name Kapani is a European. No, true-blooded Punjab gentleman who worked together at the Imperial College in London, and they worked on image transmission through optical fibers. This was an extremely important work, and Hopkins was able to put this into practice. He collaborated with the Karl Stoss Company of Germany, and together they made the newer and currently used rigid endoscopes using what is system of rodlets. One minute. The Kapani's work was on fiber optic light transmission. This helped to create what we needed, in the sense that formerly light which was transmitted came along with the heat which was generated by the source. With using fiber optic transmission, he was able to cool the light and take only the light through, not the heat. The cold light was very, very essential in doing any sort of endoscopic work. So his work allowed the formation of cold light sources. It also allowed transmission of light as well as images across fiber optics. Next. The Hopkins telescope and Kapani's fiber optics, this ushered in the new resurgence in the interest of endoscopy and neurosurgery. Rice in 1978 reported a series of 5 patients who he had treated with endoscopic third ventriculostomy using a fiber optic endoscope. Although all of his patients eventually required a shunt procedure, they did postoperatively well, and demonstrating that endoscopic third ventriculostomy was technically feasible with the current technology. From all this, through these ages of development, we have now come to this, and it is only developing year by year, month by month. The current operating endoscopes have more than one channel. They have 2 working channels, a xenon cold light source giving excellent light, HD and now 4K video cameras, and the instruments are made of extremely low weight titanium alloys. I had the honor of working with Professor Veeraraghavan and his team at the Chandra Lakshmipathy Neurosurgical Center in 1994 as part of my surgical training. I moved from here to Frankfurt and the University of Kiel for learning the neuro-endoscopic techniques using instruments that were being developed there. I kept writing to Professor, updating him about all these instruments and their probable utility in other specialties. That's me in the corner there. Next. I was working with a Professor Kurt Sem from the University of Kiel. He was the head of the department of gynecology there. He was the first person to do a laparoscopic appendectomy with instruments which he had fabricated. He was considered a madman at that time in his own university for thinking in terms of operating with laparoscopes and other instruments instead of doing open surgeries. But now is acknowledged as the father of laparoscopic surgery all over the world. Very interesting history. He was a youngster, he was caught up in the war, he was a prisoner of war. When he was released after the end of the war, he took up the trade of tool making, which he did before he joined medicine. His tool making skills helped him in later years to develop many instruments for laparoscopic surgery. Perhaps Sem is credited with he was the most important, his development of the carbon dioxide gas insufflator was perhaps the most critical invention of his, which makes the entire laparoscopic procedure safe prior to what it was earlier on when intra-abdominal pressures were unregulated. While working with Professor Sem in Kiel, I received the following letter from Professor Veeraraghavan. This is where he wrote thanking me for the letter which I had written to him of all the instrumentation and the expertise in various fields of endoscopy. And then the second paragraph is a paragraph which perhaps I will say was critical in inducing me to come back to India, where he says that you need a certain amount of persistence and optimism to work under Indian conditions. This he felt that I had no doubt I possessed. But then he, most importantly, the last thing, he introduced me to Professor Hugh Griffith in Bristol. He sent me a letter along with that and asked me to go and meet him. He was working in Bristol, UK. The other side of the letter, where Madam Veeraraghavan has also written in her own hand about the work that I was doing and promising me help when I came back. I went and met Professor Griffith. He was the head of the department. Dr. Ramurthy foresaw the possibility of using the newer technology to perform ventriculoscopy and suggested that I go across to Bristol to meet and spend some time with Professor Hugh Griffith, who was the head of neurosurgery at the French Hospital. This I did. Professor Griffith was also the founder of the British Journal of Neurosurgery. He was there in 1985 doing some pioneering work on developing a ventriculoscope. He was very, very kind to show me his prototype, discuss the various problems that they were having trying to use it, and perhaps in a very small way I was able to update him on the newer instruments and sheets which were being developed in Germany. On return to India, we set about trying to make a ventriculoscope. But then the machining industry at that point in time was in a very primitive stage, and it was very, very difficult to make much headway. All the instruments that we were able to fashion with the lathe machines of that particular time were very crude. We never did feel very safe in wanting to use it or even attempting to use it. Next. It was finally, I was fortunate to be introduced to this gentleman, Mr. Rajiv Chowdhury, who had set up a precision lathe machine shop for manufacturing components for the automotive industries. His shop was called the Autocraft Machine Shop. It was in Nandambakam, right across the current Chennai Trade Fair Center. He was very enthusiastic. He helped in making the ventriculoscopic sheath and trocar using polished stainless steel. This was finally the sheath that we used. He also helped me to fabricate the monopolar electrodes, which were insulated, which you could pass alongside the optic to go out. We were very thankful to him for having given the timely assistance which made the procedure possible. Some of the things, the sheath was what, in the corner was what we made. It looks very simple now, but at that point in time it was high technology. The optics that we used were the pediatric cystoscope which we had in the hospital at that point in time. This is a rod lens, Hopkins rod lens system. And we also did have a pediatric rhinopharyngoscope made by Olympus. This was also another optic that we used. The sheath that we made allowed either the rigid optic, Stowe's optic, or the flexible Olympus scope to pass within, but still allowed a certain amount of space for the electrode, the Ratham electrode to go in, or to get a shunt tube in. It was an end in 1987 before we were finally satisfied that setup was okay and there was a possibility of utilizing it. At that time, you must remember, in that era there was no video recording possible. Even recording with still cameras was a very, very difficult thing to do. There are a few pictures that we have from that period which I will show to you later. Finally, on the 20th of February 1988, we had this 14-year-old girl from Pollachi near Coimbatore who had presented a few days earlier with a suprasellar arachnoid cyst with obstructive hydrocephalus, and ventriculoscopy was decided upon. I must at this stage mention that very grateful to Dr. M.C. Vasudevan and Professor Ravi Ramurthy, who stood with me and helped me to go through with this procedure at that point in time. I'm very grateful to them for that. Next. The presentation of the child, on and off vomiting for 3 months, had deterioration of vision over the previous 1 month, drowsiness and urinary incontinence over the previous day. On examination was drowsy, rousable, fundi bilateral optic atrophy, facial weakness on the right side limbs 3/5, both lower limbs hypertonic, exaggerated reflexes, plantar bilateral extensor. The procedure details: under GA, the existing shunt wound was opened and the pump and the ventricular end were removed. The trocar and cannula were inserted through this opening into the occipital horn. The ventricloscope was introduced and the cyst wall was seen. The cyst wall, we used the monopolar diathermy electrode, made an opening into the cyst wall, clear fluid came gushing out. Then we found another membrane out there, which was seen just deeper to this. This was also opened using the electrode, and more clear fluid came. With a lot of difficulty, we were able to take the shunt tube into the cyst, and the pump was then fixed. Post-procedure, the girl had a febrile episode due to urinary tract infection, which was treated with antibiotics. CT done 6 days later showed that the ventricular end of the shunt tube, it was in place. The cyst size was diminished. A few days later, to assess the cyst pressure, through the frontal burr hole, the cyst was tapped, CSF was clear and under low tension. A repeat scan also showed diminished size of the cyst. So these are some of those. You can understand they are so crude, the images that we took on that particular day. The passage through the brain matter and entering into the opening we made to enter into the ventricle. Thank you very much for giving me this opportunity.